talk a little bit about interventions for acute and chronic spine pain. Let's start off by the acute phase. Can you talk a little bit about interventions for acute spine pain?
Sure. So as far as the evidence, the first two papers that I use as kind of a mental model for how I address acute spine pain is the American College of Physicians have guidelines that they released in 2017. And then also, I mentioned it in the first episode as well, but there's a paper by Johan Blayen. It's a primer in the Nature journal, just titled Low Back Pain. Both of them lay out an algorithmic approach to pain. And for acute spine pain, you really don't have to do too much. I think sometimes we can overdo it. But the recommendations include things like spinal manipulative therapy, superficial heat, massage, and then all the helpful advice and education we mentioned in the first episode. So I think there's a lot of wiggle room for kind of putting your own twist on what you do. This is why we see so many different techniques, so many different approaches to acute spine pain, because if you just take a step back and look outside the box, there's a 4 to 6 week natural history. So any case of non-specific low back pain that occurs, if you just did nothing for 4 or 6 weeks, it's likely going to get better on its own. It's a self-limiting condition. So that's why, primarily why I said that chronic pain is a greater passion of mine in studying, because you do have to deliver the right interventions, or you do have to take an active approach to the care, because you're stopping a perpetual cycle, whereas in acute pain, you're just preventing this cycle from occurring.
Yeah, once again, regression to the mean when it comes to acute pain.
Mm-hmm.
So let's talk about chronic spine pain, which we know it's a lot more complex than acute.
Yeah, and hopefully I got the message across in the first episode that when it comes to chronic spine pain, it's a very subjective and individualistic approach that you have to take. So you have to utilize the entire spectrum of the biopsychosocial model, which is a buzz term. I know it's used. It's the current model of care. And I'll throw in the behavioral model. I kind of bounce between using those two terms. So obviously you have to get to know the person. You have to understand what barriers there are, what perpetuating factors are involved. So maybe we can discuss that later, as far as what are the most common risk factors, or most common, underlying or comorbid conditions. But a lot of it is, I would break it down into, this is the way I've organized my research paper, is there's patient clinician care, and then there's patient self-care. And so under the umbrella of patient clinician care, first you have the conversation that you have. So this will consist of advice that you give them, education, which is different from advice, and then goal setting and making these plans of action. So under advice, this is your return to work, stay active, movement is better than sitting around doing nothing. And then education is a bit more when you start to address the subjective nature of their pain. You address their common mythical beliefs about their pain. You inform them of, if you want to go down the rabbit hole, a little bit of pain neuroscience. We know that the more people understand pain neurophysiology without boring them, if they can actually grasp it and understand it and they enjoy it, it will reduce fear avoidant behaviors and poor coping mechanisms, because they have a better understanding of the pain. And then, the third component of like the education or the sit down talk would be like the goal setting, and thinking of things specifically that they need to change, or things that they want to get back to doing. Like, I want to be able to do all the dishes in one go, without having to take a break, or I want to do yard work without feeling like I need to be bedridden for the next 3 days. So these are where you start to have to implement strategies like pacing. Pacing is a strategy commonly used for certain patient demographics, typically with an anxiety-based persona. So not doing too much at once, but also not being underactive. You got to find like that wiggle room and start planning out your progression of rehab.
So how do you explain chronic spine pain neurophysiology to someone that doesn't know a lot like you do? How do you dumb it down?
I think the guitar and amplifier, I haven't used that in clinic, but it kind of just occurred to me, and in retrospect, I like it. So you can describe, you know, the hard part is not telling the patient it's all in your head. That's what you want to avoid.
Mm.
But explaining that, you know, your nervous system is set up to protect you, and that sometimes this alarm just gets triggered too easily, and the thermostat can be set too high or too low. You can use a lot of analogies, but that is an art, and I don't have an answer, quite honestly.
Yeah.
I know there's YouTube videos by Lorimer Mosley, who wrote Explain Pain. He has
Mm.
a roughly like a 5-minute cartoon video that he made explaining chronic pain, and it's called Tame the Beast. That's something I would jump to right away, at least until I've generated my own improved way
Your own
of,
style, yeah.
yeah, my own style. So yeah. And then as far as treatment for chronic pain, after you have the whatever conversations that need to be had, you start moving on to in-office care. Um, I described patient clinician care under a few other umbrellas again. So you can take a strictly psychological approach, which can be viewed as just a counseling based, some form of conversation, but you're implementing specific strategies. And I'm thinking of things like pain cognitive behavioral therapy, acceptance and commitment therapy, mindfulness based stress reduction. A lot of these things are just, again, diving deeper into the person's beliefs, their perceptions, the associations they make with their pain and outside influences. And then you can transition these psychological interventions to what I consider mind body therapies, is the way I look at it. So it's a combination of, you got to have the right thinking processes, the right um, mindfulness, I suppose. And then you're combining a little bit of active care. So in this, I'm including things like diaphragmatic breathing is a good one. So we're trying to generate an autonomic response that's more parasympathetically oriented. So mindful breathing is a really big one. I really like progressive muscle relaxation, or PMRs.
Okay.
Are you familiar with that? So essentially, there's a lot of different ways to do it, but the overall premise is you start head to toe or the other way, and you squeeze a muscle for about 8 seconds as hard as you can, and then you relax it, and you 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 let them know that what you're doing is trying to regain the skill
Mm.
of mind body connection and relaxing muscles. And so it's doing a couple things at once. It's exposing the person to a transient increase in their pain, and also there's a large autonomic component to what we're doing with these mind body therapies. We're trying to reduce sympathetic activity, improve parasympathetic activity, which is going to relax muscles. It's going to reduce respiration rate, heart rate, and overall, it's going to kind of retrain the autonomic nervous system on how to respond to pain, or how responsive it is to pain.
So besides those two exercises that you said, what kind of exercise would you recommend for someone with chronic pain? Like, because there's lots of different exercises, like
Sure.
for example, weight training, just walking, and
Yeah.
like general cardiovascular exercise. Like, and I know it depends with the patient's goals and all of that, but what would you say is the best, if there is a best form of exercise?
Um, to some extent, I've found that certain comorbid conditions would immediately make me think of certain interventions along this spectrum. So, for instance, people with an underlying anxiety disorder, or even if it's undiagnosable, but you can just detect it, their overall presence is that they're very high energy. They have a lot of muscle stiffness, tension. They seem to lack that ability to sit back and relax. This is where I would consider mindful breathing or the PMRs,
Okay.
because it's just you see it in them in their presentation, and these are things you over time that I've gained the ability to recognize during a history. But in the like, yeah, there's no best intervention. It's something that I think you can pick one or the other, and they might both be helpful, or you might combine the two. And obviously, you got to revert back to patient values and patient preferences, and whichever one you think they're most likely to hold on to and continue doing. So compliance is a really big component of choosing which exercises you prescribe. So it goes back to goal-oriented care. If someone needs strength, or they disclose to you that they want to become stronger or something of that nature, then yeah, maybe strength training and weightlifting is their thing. And then the next person has no interest in regaining their strength. They don't disclose to you any functional impairments. Maybe it's more of an emotional cause. So that's when emotional causes can be addressed with the cognitive behavioral therapies, the ACT, MBSR. So it's all kind of just based on, I'm not saying you can put patients into a box or you could subclassify them. I really don't like subclassifying patients. But there is a component of pattern recognition, I believe.
What does the timeline look like? So we talked about how the regression to the mean is about 4 to 6 weeks with an acute issue. So what does a typical timeline look like for a chronic case?
Are you asking about one that responds to care and is
exactly, yeah, just like a typical one?
That's they're all different.
Right.
I have seen, because I've only been at the current clinic I'm working in for 12 this month. So I've seen some people who fully resolved or have had significant improvement of a chronic condition. I've seen others who we refer to it as the yo-yo effect. So people who are very emotionally driven, with or without, like, say, bipolar disorder as a diagnosis, they're very reactive from an emotional sense to events. These people, one day they may be feeling like they're 80% better, they're smiling, they're hugging you, and then they come in the next week and they're back down to like 20% improvement. They had a bad life event. So it is a spectrum. It's a constant up and down, which is why the behavioral approach is what I prefer to advocate for. You're not just alleviating a condition and then you wipe it away for good. You're trying to change this person's entire life for eternity, really. Some people, their pain is just, they need to understand it, overcome it, and they're really good at becoming like a self-managing person. They really are empowered, and they take care of themselves, and they come in one day and say, I'll just come and see you every few months, just as a tune-up kind of thing. But yeah, I've seen a lot of other patients who they just wax and wane, and we call it the yo-yo, which is a really good learning point too, because it reminds you that you really need to be neutral yourself. You need to remain stoic throughout care, because if you meet people at their level of happiness, the days they come in feeling really great, are you also going to meet them when they're feeling really down? So it's good to kind of just be that neutral voice for them to kind of be chained to.
So since we know that outcomes vary like greatly between patients, how do you set expectations? Like, for example, for acute pain, we can say in 4 to 6 weeks, the odds are you're going to be a lot better, or even like without pain. So when it comes to chronic spine pain, how do you set expectations? Like, do you not mention a time frame, or do you just give like a tentative time frame, or?
Yeah, no, we don't give a time frame. We don't say you're going to be feeling this good at this point, because we know how subjective it is. So we give them realistic expectations. We say, a lot of this, the ball's in your court. The more the more compliant, or the more you do these exercises, or the more you do this or this therapy that we've given you to do at home, the better you're going to start feeling over time. And we kind of frame it in a baby steps kind of format, that as long as you're continuing in this direction, you should start seeing positive outcomes. But then we also remind them, back pain is a normal part of life. It comes and goes. You might have good days, bad days. So as long as you stay the course and you look at the big picture and not get too down, don't beat yourself up if things get worse one day. There's a lot of different ways to frame it. It's a lot of different ways to deliver this expectation. It's just gauging who this person is and understanding what their current expectations are. Do they think they're going to get better? Do they have the belief that they're stuck with this pain forever? So that's where a lot of the tangents can kind of take you down different conversations.
So I remember we were talking a little bit yesterday about what we were going to talk today. Can you talk a little bit about the neuroplastic changes that occur in the brain of people with chronic low back pain?
Yeah. This was a fun topic of study for me when I was really heavy in like studying neurology and functional MRI, plastic changes. So we talked a little bit about the guitar and the amplifier and how in central sensitization, we'll call it, other people call it nociplastic changes or nociplastic pain. There is an anatomical structural change in a person's brain when they suffer pain. And it's really important to know this because some people have trouble understanding the biopsychosocial model. They look at it as 3 individual hyphenated terms. So it's like either they're a biological patient or the term is always they're a psychosocial case, which is a pet peeve of mine. Every patient is a biopsychosocial patient. Every patient has a working functional network of central nervous system integration of pain and other somatosensory input. And so, some of the major brain changes we see, they're perpetuated by 2 major physiological mechanisms. And these physiological mechanisms are going to be what we try to target with our care if you were to step back and look at the big picture. So the 2 I'm thinking of are the HPA axis, the hypothalamic pituitary adrenal axis, and then also the sympathetic nervous system. And they hold hands, but they're the 2 major controlling systems in the central nervous system. One will have more of an endocrine output, and one will have an autonomic nervous system output, but together they make up the stress response system. And so there is a third component to this, which I'll touch on, is an immune reaction. So there's a neuroinflammatory response to pain. But starting with like the HPA axis, when you suffer from pain or you feel pain, you have a stress response. We all are familiar with cortisol and stress hormones, as we call them. And these alter our physiology. So they provide perfusion to different areas of our body. They provide changes in heart rate, respiration rate, skin temperature. So we have all this fight or flight activation that puts us in survival mode. And so what we've learned in studying chronic pain is that pain and stress, like, it's a bidirectional relationship. So when you're in pain, you're stressed out. When you're stressed out, your pain amplifies or gets worse. And so a lot of this is mediated by like cortisol and similar glucocorticoid hormones. And so part of what this does to the brain, cortisol specifically, is it causes retraction of dendritic synapses in certain functional networks. So what's happening is we're losing the functional connectivity in certain areas that are primed or meant to control pain and emotional responses to pain. So if you view the central nervous system the way I do, as a series of reflexes that are just constantly being inhibited rather than a bunch of like on buttons being pressed, it's kind of the other way around, right? Yeah. Everything wants to fire and we're just holding it down, like holding a leash of a bunch of dogs trying to run away. We start losing control or losing grip on some of those leashes and the dogs are able to run off. So this is why you see in chronic pain that there's a hyperreactivity from an emotional and a cognitive perspective, because they suddenly just lose the ability to respond to pain. So one of the central areas of the brain that is kind of what I would consider the central hub for a lot of these plastic changes is the medial prefrontal cortex. Because to me, the way I view it, if I were to simplify a very complex study, the medial prefrontal cortex is the bridge between higher cognitive functioning. So like the dorsolateral prefrontal cortex, kind of what separates us from animals. This is where we do all of our higher thinking and planning and judging, all the things that turns out work against us in chronic pain. And then it bridges with the fear conditioning triad, or the lizard brain, the hypothalamus, the amygdala, the hippocampus, all of these emotionally and endocrine based structures. And so when we lose the ability to, let's say, cognitively influence our emotions, then our emotions are just simply reflexive. So to give you an example, mindfulness meditation, which is one of the interventions for chronic pain, mindfulness is what gives you this cognitive awareness of the way you're reacting, the way you're viewing the world, and the way you're letting the world influence your behavior. Mindfulness from a brain-based perspective is the prefrontal cortex regaining control over these deeper centers, these fear-based centers. I don't know if you can hear that in the background, but my dog really wants to get out of the room.
It's okay.
Got distracted for a second. So a lot of the medial prefrontal cortex in chronic pain, we see that it starts to atrophy, or they call it pseudo-atrophy, because there's not any cell death, but there is a loss of functional connection. So a lot of the primary functions of the medial prefrontal cortex are things like executive control and emotional control and learning. And so if you lose this ability to do it actively or consciously, then you're just left with a series of reflexes that you seem to have no control over. So
as MSK healthcare professionals, how do you help people with like high level stress and that we know that's causing or affecting their chronic pain? Do you just use like the mindfulness and the cognitive behavior therapies or any sort of stress coping mechanisms?
A lot of the interventions that you probably already think of I just view them differently now. So exercise in and of itself builds resilience, and it's a stress on the body, so that then builds the resilience of the sympathetic nervous system. So you can think of it from that perspective. We also kind of touched on how it eliminates fear and fear avoidant behaviors, but I look at the same interventions that have always been mentioned in the literature. I just view them differently now.
Yeah.
So mindful breathing. I mean, it used to be that diaphragmatic breathing, the way I was originally taught is that breathing properly from diaphragm, it's a lumbar spine stabilizer, which is more of a biomedical perspective of what's causing their back pain. But now I look at it as, no, there's an autonomic response to diaphragmatic breathing. Your gut is filled with C fibers and a lot of parasympathetic innervation. So the more you can stimulate that, the more you can reduce stress-based responses and reflexes. Same for cognitive control. So cognition is one of the highest levels of neurological activity we can perform. So being able to quite literally think yourself out of pain, or to think yourself out of being threatened by your pain, that goes a long way from an autonomic standpoint as well. It can reduce these stress-based responses because you now don't perceive your pain as a threat to your system.
I actually just thought of a question that I don't know why I asked on the first episode. And the question would be, what kind of tools do you use to measure your patient's pain? Because we know it's so subjective, but we also know it's real. So do you use like a VAS scale, or I don't know?
So that's a really good topic, because pain is now the fifth vital sign, right? Like you have to take the VAS scale 1 to 10, that's part, or 0 to 10, that's part of your vitals, which is, it's going to contribute to rumination and thinking too much about the pain. And we know like pain-centric care kind of stunts outcomes. So we do use VAS scale on the initial visit, but we typically don't talk about it from visit to visit. We also use outcome measures. So I think these are very important and kind of overlooked in certain clinical areas that I've shadowed or worked for, that if you don't use outcome measures like disability outcome measures such as the Roland Morris or the Oswestry or neck disability index, these kinds of things, these are more important anyway because they're goal oriented. If you look at the questions on the questionnaire, it'll say things like what you're capable of doing or what you're afraid of doing. So these are the things that we're trying to change anyway. So why not take an objective measurement of what matters more? So reduction of pain intensity is important, but I would much rather someone be at the same pain intensity, but be able to live their life than vice versa. If they reduce their pain, but they're still not doing the things they love doing.
100%. What do you think about, I'm just throwing random questions that come to my mind. So what do you think about how does spinal manipulation and like cortisol shots and all of those short-term therapies, how do they affect chronic pain? And we know that they can sometimes affect it positively and also negatively. So could you give an example of when and why would you use it or why not?
Yeah. In fact, Norman Kettner, I've mentioned before, he has produced some really good research, the first of its kind in the context of spinal manipulative therapy for chronic pain and fear avoidant behaviors. They've done, and I need to go back and read this study. I hope I don't misrepresent his outcomes, but they've shown that in spinal manipulative therapy that, like with functional brain imaging, that the same pathways that are involved in fear avoidant behavior are directly affected by spinal manipulative therapy. So what they did was they have patients look at videos of like a person lifting something or something that it would evoke like a fearful like response, or, oh, I don't like watching this, it looks like he's gonna hurt his back. And then they do the spinal manipulative therapy and then have them watch the same video again, and they see a reduction in these fear-based integrative networks in the brain. So there is a lot more to it, but then again, it's just one tool in our toolbox. Like I look at it both ways. I think it's very effective in the right context. But there's other times when I don't really think anything good can come out of manipulation. Like we mentioned before, histories of abuse or maybe car accidents or all these like physical traumas where the association of something high impact, high velocity coming at you might actually produce detrimental results. So it's just an intuitive, again, like subjective. My answer is always going to be, it's a subjective, individualistic
It all
answer.
depends.
So, yeah.
That's right. I had another question here. Do you have questions?
Like I said, I'm just digesting everything you're saying, man. I'm in the back seat right now.
Can you mention a little bit more? You mentioned a little bit central sensitization. Can you dive deeper into the pathophysiology of it?
Yeah, I guess we kind of left off some of those things I was going to mention. So we talked about the HPA axis and cortisol being, from a vascular standpoint, something that will cause retraction of dendritic synapses and cause an increase in sympathetic nervous system activity. And then we've kind of discussed the sympathetic nervous system itself and its functions. And then the other one I like talking about is neuroinflammation, and also known as glial activation. Another area of study of Dr. Kettner, he's produced pretty good research on. But in neuroinflammation, what happens is, so you insult the nervous system with a noxious input. So you have an experience of pain. The immediate reflexive reaction of the neuroimmune system is that you become pro-inflammatory. So microglia and astrocytes will release chemical mediators, inflammatory mediators, primarily interleukin 1B, interleukin 6, tumor necrosis factor alpha, all these things that will sensitize nerves, make them fire more easily. So you can see over a long period of time, when this doesn't reduce back down to like homeostatic levels, that you're just chronically making the nervous system fire more easily. And so you become more sensitized to pain. And that's where we get the term central sensitization. So it can start in the periphery. This is part of Dr. Kettner's research, was it can start in the periphery. You can have peripheral sensitization that migrates to the cord and then up into the brain. And so we see a lot of this in different brain areas. So I mentioned Dr. Claw. He's a rheumatologist and studies a lot of this glial activation. So if you just take inflammation and you were just to implant it into different areas of the brain, you get different outcomes, but they look similar. So say I put some inflammation, I inject inflammatory cytokines into S1, the somatosensory cortex, where it represents the low back. Well, now you get chronically sensitized low back pain. If I were to spread it throughout the entire brain, then we get things like fibromyalgia, where there's a cognitive effect, there's fatigue and lethargy and all these other symptoms. So just based on where you have inflammation, you have sensitization of the nervous system, and you have an increase in firing. It's something that you have to reverse. And so I don't want to say that you can take a biomedical approach to this, because I still think at the end of the day, it's a functional neurological issue. And so you've got to directly have some form of behavioral and functional approach to it, rather than just saying, oh, well, the problem's inflammation, we just need to give them some kind of anti-inflammatory measures.
So do you think, or does evidence say that chronic spine pain, can it exist without a prior acute phase? Did I word that correctly? Did you
I see what
understand
you're
it?
saying. Without like an initial injury?
Yeah, without any sort of tissue damage at all, because we know that sometimes
Right.
the acute phase turns into the chronic phase, but
Yeah.
can the chronic phase happen without the prior acute phase?
Yeah, I would argue that most does. And so most research says that it'll say, while an acute injury can, start the cycle of chronic pain, most chronic pain is insidious. And so that's why we go back to the perspective of the diminished anti-nociception rather than the pro-nociception. So it's not an increase in insult, but it's a reduction of resilience to, spontaneous firing. So yeah, most pain, and you'll see this, and it really depends on the practice you have and the patients you see. Everyone's going to have their own reputation and get different experiences based on who they treat. But a lot of the times, and this isn't just where I work, where I see a kind of a unique demographic, but I've shadowed and worked for other clinics, and 9 times out of 10, the patient history is, I have pain, I don't know what caused it or where it came from, it just came out of nowhere. So the ones that say, I was lifting something and felt a pop or something where it kind of gives you that inclination that there's an actual injury or tissue damage, those are the ones that they heal anyway. So it's just a matter of where you're going to place your research focus and your studying focus, because there's difficult cases and there's easy cases. But yeah, what I've noticed is the majority of cases are insidious, idiopathic, no particular trauma or event that caused this pain to start.
Yeah, same here. I just wanted to see your intake, because there's lots of different ideas. We've heard crazy ideas, but I'm on the same boat as you are.
So you were talking about how different areas of the brain that become inflamed would have a specific and unique outcome to where they would express the pain. I was just reverting back to my previous question back into part 1 was why low back pain? Do you think there might be a common area in the brain that becomes inflamed, or like more prone to becoming inflamed? I know this might not be proven in research, but this is more like a hypothetical.
Gotcha. I'm trying to think of the somatotopic orientation of the somatosensory cortex, and the low back is in that watershed zone. So it is like the least perfused area. So there could be a little component to that. I still think it's based on if you took any area of the body, the knee, the hip, the neck, the low back, like the low back is where people misunderstand so many of these common myths. So we talked about, like, the number 1 myth is that most people think that low back pain is caused by an injury or heavy lifting. But there's also a lot of other ones out there. So that the number 1 thing, or I think it was like 60% of patients believe that if I have back pain, that bed rest is the first thing that I should do. So these are going to influence behaviors, and we're going back to the behavioral talk. Most people believe back pain is typically disabling, or that if I have back pain, I need to go get an X-ray or an MRI, because there's got to be something that's causing this. I have to have some kind of condition causing this. Most people find it hard to believe that there is such thing as non-specific pain. I think even in healthcare providers too, a lot of people don't buy into the non-specific pain talk. I won't say names, but everyone's going to know who I'm talking about. I mean, there's big names out there that say there's no such thing as non-specific pain, and that there's a cause for every type of pain. I believe there is, but it's not an anatomical cause. I think it's a functional neurological cause, and you got to understand all the different multifactorial risk factors that might reduce, pain inhibition.
Do you ever screen for depression on your history, or can you just personally sense it?
Where I currently work, I mean, we get referrals from primary care, so it's typically already diagnosed.
Okay.
But once I'm out and I'm not in an environment where, you know, I'm as privileged as I am now, there's the PHQ-9 questionnaire.
Yeah.
So yeah, I mean, once you've seen it or you can imagine it, you know, I mean, some people hide it to be fair. Some people hide their feelings. So yeah, I mean, there's plenty of questionnaires out there that are, I know they're objective. They're not like the same as having a conversation with somebody, but the conversation, the history is inevitable, right? So you're going to pick up on subjective measures of depression. Why not throw in an objective way to identify it or screen for it? And even if it's not the clinical diagnosis of depression, you can still screen for the beliefs and perceptions that go into the chronification of pain, which is what's on the start back. If you really examined the start back questionnaire, there's one individual question for like the top 5 thoughts or risk factors for chronic pain. There's one about, I have worrying thoughts about my pain, or this is the worst pain ever, it's never going to get better. So there's catastrophization. There's man, I can't recite it, but if you print it off yourself, the start back questionnaire, it's only 9 questions, but there's a subscore. So questions 5 through 9 are, if you were to take each sentence, you could say, oh, this one is looking for depressive signs. This one's looking for anxious signs. This one's looking for catastrophizing thoughts. And so you can look at each one and dissect it. And so that's why I'm a really big advocate of that screening tool, as is the evidence.
Yeah, I'm good. I'm good. I got, like, every time we have this conversation, I just have a paper full of notes that I know I have to go over and digest it all. So like it's definitely impedes my question asking abilities because I'm just so busy writing everything.
Right. Well, I did want to recommend one more paper for you to add to that list. So a good friend of mine and some colleagues I follow on Twitter, I still haven't read the paper. I refuse to until I've finished my own project because I know it's going to reinforce my own beliefs. But there was a recent publication of a book called Meanings of Pain, Volume 2. And one of my closer friends and colleagues helped author it. And it's Chapter 5, Changing Pain, Making Sense of Rehabilitation in Persistent Spine Pain. So if you wanted another resource, it's a very well written. I've skimmed through it. I just won't read it all because I don't want to like copy his work, and I know I would be biased towards it. But it's a really well designed paper, and it talks about a lot of the same things I'm studying and a lot of the same things we've discussed today.
It's going to be my next rabbit hole then.
Yeah. I'll give you books and article recommendations for days. So
sweet.
There's no shortage there.
I guess like, you know, this can be like off air